Good morning, ladies and gentlemen. Good afternoon and good evening. Thank you for joining us for this event dedicated to the African region. The title of the event is Understanding and Managing Headache in the Community, Therapeutic Approaches and Advancement in the African region. Before starting, a few announcements. This webinar is being recorded and live streamed via YouTube. The recording will be available in our website, www.event.fr.org. You may ask questions using the question box provided. You are welcome to provide feedback to webinars@fip.org. Become also a member of FIP at www.fip.org/membership.registration. My name is Prosper Yag. I'm the president of the African Pharmaceutical Forum. I would like now to thank Sanofi who has supported us for this online event and making the participation of Professor Godsby possible. Thank you, Sanofi. Our program. After the welcoming speech, we are now going to have this program summary video message from Professor Peter Godsby, a recorded presentation on therapeutic approaches and advancement in headache management by Professor Tokuya Kumamoto, and regional approaches to headache self-care leading prescription medicines by Dr. Luminita Constantin. At the end, we have an experience from Africa, from pharmacist's role in supporting the self-care of headache in Africa region by Dr. Mash. The learning objectives. First, provide insights of the therapeutic approaches and advancement used in the management of headaches. Two, understand the role of non-prescription medicines as a tool in headache healthcare. Three, identify the role of pharmacists in supporting the self-care of headache through the region lens. I would like now to introduce Professor Peter Godsby, who will speak about understanding 21st century headache and their impact on patient well-being and quality of life. Professor Peter Godsby is Professor of Neurology, King's College London, and Director, NIH Wellcome Trust Clinical Research Facility, King's College Hospital, London. He is also a Professor of Neurology in the Department of Neurology, University of California in Los Angeles. He is honorary consultant neurologist in the Hospital for Sick Children, Great Ormond, St. London. Let's watch the video, please.
Hello, my name is Peter Goadsby, and I'd like to thank the International Pharmaceutical Federation for asking me to speak at these series of meetings about 21st century headache and the way headache is impacting well-being and quality of life. I'm a neurologist and I'm interested in headache disorders. One of the realizations of some work I've been doing with colleagues in the last year and a half to 2 years is that a large number of people, perhaps the largest group of people with headache disorders, don't actually see doctors. And to be simple, we've referred to this as non-doctor treated headache. So on the left, if you look at the population of people who actually seek medical care, who are treated by doctors, about 10% only end up with a neurologist. About 20% of patients end up with a primary care doctor. However, at least 50% of patients with a primary headache disorder self-treat. This is the non-doctor population. It varies a little bit between countries, and I've been working with colleagues, as you can see, from the UK, France, Germany, Brazil, Japan, and Australia. Broadly speaking, very clearly, the largest group do not see doctors. In particular, tension type headache is overwhelmingly treated without consulting a physician. Where does the pharmacist fit in all of this? Well, migraine itself, commonest disabling form of headache, has been stable at the very top, in the top 10 of the leading causes of years lost disability over the last 30 years. What is notable is an increase in the analgesic market and an increase in medication overuse headache, as you can see, from 23rd most common to the 20th most common disorder in 2015. Pharmacists have a really important role here in providing advice to patients on the use of over-the-counter medicines for pain management, particularly in headache, and advice about the misuse or overuse of those medicines. We can help patients understand what's happening by helping them collect their own information, helping them keep a record, and using analgesics optimally. Now, from real-world data we've collected using the Migraine Buddy app, it's clear that most patients with headache, or indeed with migraine, will have up to 4 attacks per month. As you see, the vast majority will have less than 2 or between 2 and 4, and the very smaller group, which come to see headache specialists and neurologists, are those that have many more attacks a month. Certainly, our clinics are full of patients with more than 10 attacks per month. Now, patients report in their diaries missed work, social activity, and family time. They report being slower in what they do, slowed up at work. They report difficulties with sleep and difficulties with concentration, impacts in their daily life. For the management of tension type headache and for migraine, it's important to be aware of what's available, and particularly for tension type headache, given most of the management is going to be done outside the physician sphere. We know from the evidence, nice report, review that Ashina and colleagues published this year, that aspirin and acetaminophen, in parentheses paracetamol, or caffeine combinations or non-steroidal anti-inflammatories are the top options for the treatment of an attack of tension type headache. For prevention, lifestyle modification, acupuncture has a role, and tricyclics such as amitriptyline, other medicines, mirtazapine, venlafaxine, as preventives if they need to go on and see a physician. You'll see the distribution is rather similar throughout the world, with about 85%, 86% of patients all over using a non-steroidal, about 70% paracetamol, acetaminophen, and about 50% aspirin, with a little bit of regional variation. Remarkably, in the 21st century, of those with a primary headache disorder, 50% self-treat, and only 20% see a primary care physician. Remember that migraine is the most common disabling primary headache disorder. Lifestyle things are important. Sleep disturbance facilitates headache and often can be associated with cognitive dysfunction. We're obtaining robust real-world evidence from e-diaries, population-based. Most of the patients in these diaries have less than 4 attacks a month, and thus primary headache disorders can often be well managed by pharmacists. There's an enormous amount of good to be done. I'd encourage you all to do it. Thank you.
Okay, thank you for listening to Professor Gotts. Now we are going to listen to a recorded presentation of Professor Takuya Kumamoto. The title is Therapeutic Approaches and Advancement in Headache Management. Professor Takuya is Chief Department of Synthetic Organic Chemistry, Graduate School of Biomedical and Health Science, Hiroshima University in Japan. You have the floor, Professor.
Hello everyone, I am Takuya Kumamoto from FIP BPS New Medicine SIG and Hiroshima University, Japan. Today, I will talk about therapeutic approaches and advancement in headache management. According to the International Classification of the Headache Disorder, migraine and attention type headache, a main part of the 21st century headache, were recognized into primary headaches, which caused by their headaches by themselves. Other headaches associated with other factors, such as injury, vascular or non-vascular disorder, infections, other medicines and its withdrawal, are categorized into the secondary headaches. Usually, the secondary headaches become an urgent case, and if you can observe the patient with a sudden and unusual headaches or a high fever or change of their mind states, immediate consultation of the doctor will be recommended. Here lists the medicine used for the headaches, including prescribed medicines. The list of some information in this talk were collected from the guideline of the chronic headaches published by Japanese Society of Neurology and Japanese Headache Society, and translated in English and published on the web. For prevention use, the calcium channel blockers, beta blockers, S inhibitor, ARB, anti-epilepsy, and antidepressant are used. For the acute therapy, NSAIDs, acetaminophen, ergotamine, and antiemetics are used. Triptans are also used for the acute therapy. The chemical structure is related to the serotonin, and its mode of action was at first assumed to cover the shortage of serotonin. However, recent research suggests that the triptan works to binding its receptor on the trigeminal nerve to control the release of the neuropeptide. Safety of the triptans was suspected for the patient with cardiovascular risk factors because of the vasoconstriction activity. Towards this issue, Recently, new type of the selective serotonin 1F receptor agonist were approved. As shown in chemical structure, it was different structure from those of serotonin or tryptans. And so the selectivity is expected on its vasoconstrictions. Regarding the neuropeptide named CGRP, it was reported to be released from trigeminal nerve and to bind CGRP receptors on the brain blood vessels to induce the neurologic inflammatory developing to the migraine. Towards this issue, CGRP itself and its receptor become target of the drug discovery, and their monoclonal antibody which binds to CGRP itself and the CGRP receptor were developed to inhibit the functions of CGRP, and they are recently approved for the acute and prevention use. Small molecular CGRP receptor antagonists, so-called GEPANs, were also approved for the acute therapy. For the treatment of the tension type headache, NSAIDs, caffeine, antidepressant, and muscle relaxants are used. For OTC, single drugs of the acetaminophen, NSAIDs such as aspirin like ibuprofen are used. Loxaprophen is approved as OTC in Japan. As a combination product, aspirin, acetaminophen, or both combined with caffeine or sedative drugs are used. As the type, combination of isopropyl antipyrin, acetaminophen, anhydrous caffeine, and isopropyl acetylurea is also used in Japan. In several countries such as UK and Germany, some triptans were approved as OTC. The problem with OTC access to triptan is overuse. Pharmacists should warn and advise the patient to use a triptan on less than 10 days per month. For natural herbal medicines, Kampo medicines are approved as OTC in Japan. Some of them would be used for the headache, for example, Kakkonto, Goshirto, and Goreisan. For the preparation of this talk, I will discuss with a community pharmacist in the case of the headache patient visits pharmacy. One pharmacist pointed out the headaches are more common in women, so it is recommended to think about the balance of the hormone change for their scheduling, because headaches may vary depending on their menstrual cycle. Also recommended to pay attention to the weather change because its change in the atmospheric pressure can affect to their headaches. Other pharmacists pointed out the patient who are buying ibuprofen OTC even though NSAIDs has been prescribed, and the other patient prescribed NSAIDs from multiple medical institutions. Most of them seems not aware of the relationship between headache and their lifestyle, for example, as possible trigger for the headaches like lights, smells, smoke, sleep, alcohol, and exercise. Pharmacists can support such a patient by asking their lifestyle and the timing and the strength of the headache attack to improve the lifestyle and reduce the number of the medications. And it is also pointed out if they are taking the medicine more than 10 days per month, medicine overuse headache would be suspected. As an example of the short-term interview of the headaches, screening the questionnaire forms are useful, such as 3-question headache screening, ID migraine screening, Midas instruments, HIT6, and HAUT index. It is valuable to collect the information with a limited number of the questions. And it is not might be a special method, but the other method can be used for the interview form consists with the following 7 questions with location, quality and quantity, timing and setting, factor, associated manifestations, and additionally lifestyle and drug history. For example, a patient has tightened pain at the back of the head, which continued from 1 year before and occurred once per month, and this time from today's afternoon, and getting long-term working PC strength and the evening, and weakened by the rest. In this case, it can be from the tension type headache. As the other patient claims severe headaches in head, catching a cold 3 days ago and getting worse from the last night. And it was with a simple training of the head and cough associated with high fever, chill, and nausea. In this case, headaches by the infection should be suspected. Headache diary can support the patient with recording their headache attacks, symptoms, and treatment. It can help doctor to make a diagnosis, and pharmacists can use for the advice. Patients themselves can recognize triggers or warning signs, assess whether their acute and preventive medication is working, and show any patterns of attack. Regarding to the weather-associated headaches, what weather can be triggers such as change of the humidity and temperature, storms, extremely dry conditions, and dusty environments. For the management of these kinds of headaches, research like a smartphone application to inform the weather forecast can be applicable to avoid such headaches in advance. As a possible medications, analgesics can be used, and compound medicines can be used as OTC in Japan, for example, with Goreisan. As take-home messages, several prescribed medicines and OTC are effective for the treatment, acute or prevention for the migraine and tension type headache. Approval of a recently developed triptan derivative and CGRP-related medicines increase the choice of the treatment of the headaches. Pharmacists can support a patient to reflect their lifestyle relating to headache, which can lead to the improvement of their lifestyle and reduction of the medications. Utilization of headache diary and the digital tool for the weather-associated headaches will be also effective to manage the headache. Medicine overuse headaches can be suspected when the patient takes headache medication over 10 days for 3 months. Thank you for your kind attention.
Thank you, Professor Takuya Kumamoto, for this interesting presentation. Now, the next speaker is Dr. Luminita Constantin, earning a bachelor degree as a medical doctor on University of Bucharest and having a certification in medicines development with over 25-year experience in pharmaceutical industry, working in multinational and multicultural companies, cross-functional global. She has an experience of Africa. Medical affairs professional at Sanofi, promoting safer and appropriate drug use, enhancing healthcare professional ability to make appropriate decisions in partnership with patient customers and bringing the voice of the patient into business innovation, medical insights, and also aiming to optimize experience and outcomes. Dr. Luminita, you have the floor.
Thank you, Professor Hyag. Good morning, good afternoon, good evening, all over the world. I'm so happy to be here today with you. We'll try to talk about the regional approaches to headache self-care and the leading non-prescription medicines for the African region. Next slide, please. So as it was presented already in the video, worldwide, 50% of the people with headache are estimated to be primarily self-treating without contact with healthcare professionals, except the pharmacist. For African regions, these figures raise up to 58%. So the proportion treated by primary care physician, if there are similar for the world, with the African regions, the specialist treatments, the neurologist, it's up to 5% for this region. Next slide, please. What is the prevalence of the headache disorders? We noticed that at the turn of the century, most of the world population lived in regions where prevalence of the headache was unknown and its impact was poorly understood. Lifting the Burden, a non-profit organization in official relation with the World Health Organization, was working to scale this unknown burden. And they generated the global burden of headache in 2018, an updated document to the World Headache Atlas, which was generated in 2011. Based on a program of population-based studies performed in countries for all world region, they have demonstrated a high prevalence of headache disorders, including migraine, tension type headache, medication overuse headache, and their association with impaired quality of life, substantial loss of productivity, and high economic cost in every country surveyed. For African region 2 population-based studies with standardized methodology in both countries, we are talking here about Ethiopia and Zambia, the major difference was not in all headaches, migraine, tension type, but in all headaches more than 15 days per month, and much more prevalent in Zambia, 12%, than in Ethiopia, 3%, largely associated with possible medication overuse headache, which was 7 to up to 0.7. In both countries, medication overuse headache was mainly an urban problem, and these figures can be also connected with the level of the urbanization. For the next slide, what is the headache? Thank you. What the headache impact on productivity was very similar in the two countries for all headache types, except probable medication overuse headache. Ethiopians with medication overuse headache reported much higher individual levels of missed paid work and household work rather than their Zambian counterparts, greatly countering the lower prevalence of medication overuse headache in Ethiopia. For the next slide, I would like to talk about 21st century headache. What is 21st century headache? It is an expert consensus paper published this year. It's a temporal term and opportunity, and experts from all over the world agreed on the observation that headache now is occurring earlier in life. It's attributed to this modern life, and there are contributing factors mostly associated with changing lifestyle, such as stress, bad posture, physical inactivity, sleep disturbance, poor diet, excess use of digital technology. On top, restriction who came together with the COVID-19 pandemic contributed more to increasing screen time, working from home, physiological stress, social isolation, and it was a vicious circle. So all these factors contributed to 21st century headache, which has a negative impact on concentration, on attention, on problem solving, reasoning, perception, coordination, motivation, on top of headache and pain felt at the and pain felt. And this also conducted to the to a status called blurred mind. So this means that 21st century headache, it was an impaired mental clarity associated with reduction in social interaction, absence from work, absenteeism, presence at work, but without being able to contribute. This is presenteeism, reduced productivity at work, and of course, a lifestyle compromise. What is the management? Next slide, please, of the headache. It was already presented. The main classes of drugs to treat headache disorders are analgesics, antiemetics, specific anti-migraine drugs, and prophylactic medications. Management of tension type headache starts, of course, with patient education and management of the known headache triggers. On top, symptomatic treatment is required for mild to severe headache or when headaches affect function. Global analgesic preferred, and here particularly for the African region, are addressing analgesic effect are NSAIDs, are paracetamol, acetaminophen at the same level with NSAIDs for the African region, and aspirin. So we can conclude that from the perspective of global analgesic preferred, aspirin and paracetamol are available for all regions to all income categories, and NSAIDs are available for 2/3 of the countries. But for Africa, here all are available and preferred as analgesic. Next slide. We will talk about headache medication and COVID pandemic. Beside of the obvious concern about limitation of the virus spread and providing the best possible care to infected patients, a concomitant concern has arisen in view of a possible link between the use of certain drugs, such as ibuprofen or renin-angiotensin system inhibitors, and an increased risk for COVID-19 infection. This study shared these concerns in relation to headache treatment and conclude that, based on the current evidences, there is no reason to abandon treatment of headache patients with RAS inhibitors or ibuprofen. There is no convincing evidence that either RAS blockers or ibuprofen facilitate or worsen SARS-CoV-2 infection in any type of patients, including headache patients. The next slides will show how what were the self-management, COVID, and e-commerce, and which are the recent development we capture all over the world, but also you may notice also for the African region. Q1 2020 drug sale boosted by COVID pandemics, and especially this boost was done due to consumer stockpiling of OTC they prepare for the pandemic. And also the pandemic provide a boost in e-commerce. Online spending has risen during the lockdown, and some of the patients will rest on the online for some of the consumers. Growth was driven by higher dose of NSAIDs, new ingredient combinations, and fast-acting products, smaller pack size, and also combinations which grew in the popularity. Although e-commerce of medicinal products has many benefits for patients and the pharmaceutical industry, it remains a concern for regulatory authorities worldwide due to different factors. Next slide. To conclude, for the 21st century headache and pharmacist perspective on OTC analgesia, I will take a quote presented by Professor Godsby previously. that primary headache disorders can often be well managed by the pharmacist. And you know already that you play an integral role in pain management by assisting the patients and prescribers with the selection of over-the-counter analgesics. A pharmacist may be the last healthcare professional a patient or a consumer see before utilizing an OTC product. Patients often ask pharmacists for advice when selecting their drug and their OTC analgesic. Therefore, it is very important for pharmacists to know what question to ask patients to help ensure that informed recommendations are made. The following key consideration can help you support each patient in selecting and safely using an appropriate OTC analgesic by assessing patient characteristic and medical history, by explaining the recommendation, but ensuring that the patient understands the recommendation and it was individualized. I know that each and any step requires time, and sometimes there are long lines in pharmacy asking for drugs. Maybe to select the right question for the right patient, because I will conclude with a quote. We have a world of generic drugs, but no generic patients, and every patient requires specific consideration and an individualized recommendation. This was said by Professor Barkin Robert. And I can say that for 21st century headache, this consideration is still standing strong. Thank you very much for your attention and looking forward for your question. Thank you.
Thank you, Dr. Luminita. Thank you for your quotes. We have generic medicines, but not generic patients. Right. Thank you. I wanted to remind to the participant that you can put your question in the Q&A box, please. Thank you for listening. Now, we are going to listen to Dr. Mashi Ampango, who is from Zambia. Dr. Mashi is a pediatrician, is a pediatric critical care specialist, and a clinical pharmacist researcher. He is lecturer and head of pharmacy practice and clinical pharmacy at the Faculty of Pharmacy, Nutrition, Dietetics at Lusaka Apex Medical University. He has worked as a clinical pharmacy for Ministry of Health at the University Technical Hospital for over 5 years, where he was responsible for providing specialized clinical pharmacy services. Dr. Mashi is the president of the Pediatric Pharmacy Advocacy Group, a non-profit professional association representing the interest of pediatric pharmacists and their patients dedicated to improving medication therapy in children. He is also a past vice president and past national secretary for Pharmaceutical Society of Zambia and an organization of pharmacy professionals of Zambia. Dr. Mashi, you have the floor.
Thank you so much, Professor Hiag. Good morning and good afternoon. Is it evening to some? Welcome to this presentation. I'll basically be focusing on the pharmacist's role in supporting self-care of headache around Africa. But I'll basically be giving out general information on what headaches are and mainly what we encounter in Africa and how to manage them. Okay, let's go to the introduction. Okay, so on this slide, all I'll say is headaches are quite common, especially in Africa. You find about half to 3/4 of adults may have suffered from a headache within the past year. And more so, 30% of those headaches could be migraine in nature. And further, 1.7 to 4% may have had a headache in the last 15 days or in the last month. My professor used to say that everyone is entitled to a headache in their lifetime. But I know that the most common type of headache that most community pharmacists would encounter are more of the tension type and the migraine headache. The next slide. Now, the International Headache Society has divided headaches into two categories, those that are primary headache disorders and secondary headache disorders. The primary headache disorders include the migraine headache, the tension type headache, and cluster headache, while the secondary headache disorders include mainly headaches that are a symptom of another disease. The next slide. So what causes these headaches? I think most of this information has already been alluded to. There are two basic causes of headaches. There is a medical cause and a pharmacological cause. In terms of the medical cause, it could be either a stroke, could be an infection, inflammation, could be tumors, could be diseases of the eyes, ears, nose, or throat. These are a bit common in Africa. Menstruation as well, including pregnancy. On the pharmacological end, alcohol, beta blockers, barbiturates, caffeine, and its withdrawal, cannabis, corticosteroids, and withdrawal, fluoxetine, vasodilators, histamine H2 antagonists, etc., are among the causes of these headaches. The next slide. Diagnosis for headaches is a bit difficult, okay, because most of these disorders may have overlapping characteristics. So it becomes a big problem when a patient presents themselves to a pharmacy, for example, because most people just want to pick a headache just from the face of this is a headache, but we need to interrogate further so that we get more details in terms of the medical history, including the general physical and neurological examinations. So basically, we need to have an awareness of a presence as well of comorbid conditions, since patients like those who have depression, anxiety, epilepsy, and strokes may have a higher prevalence of migraine when it comes to awareness of the presence of other conditions surrounding headaches. So we need to interrogate the patient or the client further. Next. And in doing so, we may need to get the following information from the client, okay? We need to get the age, the duration, the nature and site of pain, the frequency and timing of symptoms, associated symptoms, and possibly sleep habits. So I'll quickly run through these elements I've mentioned when coming up with a diagnosis. Next slide. So when it comes to the age, what we say is that any headache, especially in children with an associated history of injury or trauma, especially to the head, or with severe pain across the back of the head, such kind of headaches in children must be referred. Okay. Similarly, elderly patients who have a headache after a fall involving a bang to the head also would require an immediate referral. Further, the prevalence of migraine may rise through early adult life and would decline around the age of the 40s or early 50s. So what we're basically saying is anybody who might present to a community pharmacy or anywhere above the age of 40 or so, most unlikely they will have a migraine type of headache. So those would ideally start showing around the age maybe of 30 or so. So that's the issue surrounding the age. The next slide. Duration. Any headache that does not respond to over-the-counter analgesics within a day may require a referral. I know as pharmacists, we may be tempted to just want to hold on to the patient without referring such kind of a person, even if they are not responding to, simple analgesic therapy, either by aspirin, as already mentioned, or acetaminophen. The next one. On the nature and site of pain, I'll give specific examples. For tension headaches, the pain is usually described as being around the base of the skull and the upper part of the neck, and could be the same both sides. This particular pain is not associated with any neck stiffness. Okay. Further, a steady or dull pain that is deep-seated, severe, and aggravated by lying down may require a referral, as this may be due to raised intracranial pressure from either a brain tumor or infection, or could be other causes. And lastly, when it comes to migraine with aura, which is otherwise known as classic migraine, it presents unilateral, affecting one side of the head, especially over the forehead. So when such a patient comes, try to find out the nature and where the actual pain is in that particular headache. Next slide. Also, if a patient is presenting with a severe pain with a rapid time peak, that kind of headache may signify a subarachnoid hemorrhage. This usually occurs when a blood vessel in the brain leaks blood into the brain tissue or cerebrospinal fluid surrounding the brain. Such kind of headaches are regarded as medical emergencies. And also sometimes sudden headaches are related to exercise or exertional headaches, or further to sexual intercourse, or what is known as coital cephalgia. These particular ones may not be dangerous. The next slide. Okay, frequency and timing of symptoms. So we should also interrogate further on the frequency of the headache and the timing of the symptoms that the patient is presenting with. A headache that is worse in the morning but improves during the day is potentially serious. This could be a sign of raised intracranial pressure. Cluster headaches may typically happen daily, roughly at the same time of the day or the night for about 2 to 3 months, each episode lasting up to about 3 hours or so. A person who has headaches of increasing frequency or severity should obviously be referred before the symptoms become worse. The next slide. And in terms of other associated symptoms, both children and adults with unsteadiness and clumsiness associated with a headache should be referred immediately. And usually such kinds also tend to lose consciousness as the headache progresses. Next. There could be also other precipitating factors, as has already been alluded to. For example, tension headaches and migraines are often precipitated by stress. Some migraine sufferers experience their attacks when they are relaxing after a period of stress. Also, certain foods have been implicated to precipitate migraine attacks, like chocolate and cheese. And migraine attacks may be precipitated by menstrual cycle or with combined hormonal contraception. The next slide. So in summary, when to refer headaches from the pharmacist's point of view. Those headaches that are associated with trauma or injury, you need to refer that. Headaches associated with high temperatures, severe headaches for more than 4 hours, suspected adverse drug reactions, headaches in children, especially those under the age of 2, severe occipital headache, headache that is worse in the morning, but then improves later, associated drowsiness, unsteadiness, visual disturbance or vomiting, any headaches that is associated with neck stiffness, and frequent and persistent headaches. All these kind of headaches should be referred. Next slide. Okay, so how do we manage headaches? I think this has been tackled already. Mostly we do manage these headaches in two ways. We could approach it as a non-pharmacologic way or pharmacological way. But basically the goal of acute treatment is to quickly relieve the headache pain as well as any associated symptoms. Also, the goal in preventive treatment is to reduce the frequency and severity of attacks. Drug choice depends on several factors, including the patient's headache type, comorbid conditions, and medication history. For the preventive treatment, the medication selected should be started at the low dose and gradually increased. Next slide. The choice of analgesia consists of three main agents. We could use paracetamol, ibuprofen, or aspirin, as already mentioned. In terms of the non-pharmacologic treatments for migraine and tension headaches, those include relaxation techniques, hypnosis, psychotherapy, physical therapy, and acupuncture. I think there should be one more slide. Okay. So basically, in summary, we need to identify the headache type, and then we need to implement acute or chronic therapies depending on the type of headache that we have encountered. But at the end of it, I think it was already mentioned, we need to avoid medication overuse. Thank you so much for listening.
Thank you, Dr. Mashi, for your recommendation and your conclusion. Now, and you can, do we have questions in the Q&A box for our panelists?
Yes, we do.
Okay. Go on.
Someone have asked, may I know what are the contents of chocolate or cheese that cause headache? Because I love eating those, and sometimes I get some headaches. I thought it's just coincidence, but then it was mentioned here. The person wants to know what the content of chocolate or cheese that may lead to headaches could be.
Okay, the question is to Luminita and maybe Mashi also.
I may try to ask, but it's a strongly debatable question. Of course, there are also some other elements which are considered. I do recall some of the studies which mention not only cheese, but chocolate, but also the red wine. So we need to be mindful. I do not know what is the quantity, but I think each and any of us who experience a headache and might be related to this food should investigate more. So maybe I'm not giving too much insights, but these are among also the triggers mentioned in the guidelines together with some other foods.
Okay, thank you. And Dr. Mashi.
Okay, so the major culprit in cheese or chocolate, especially the cheese, to cause these headaches is tyramine. So it has been shown to precipitate headaches. So it's dose dependent. So you find that in cheese or yes, mostly the tyramine levels are high.
Mm-hmm.
Okay. Another question? Anyekan?
No, that was the only question. Oh. Okay, I think another one has been asked. How can hangovers after excessive alcohol intake be treated?
Did you understand the question?
So some persons experience hangovers after they've taken excessive alcohol. So the person wants to know how that can be treated. I believe part of the effect might be headache. So probably the person is asking how that can be treated.
Okay.
It depends of the, I will try to answer. It depends of the capability of the organism to metabolize the alcohol. And if we have a good and healthy liver who can well metabolize it, we do experience less headache. So maybe the answer is to protect our liver in order not to have headache after hangover.
Okay, thank you. A brief contribution from you, Dr. Mashi.
Okay, on the hangovers, I know I've heard a lot of therapies that are being used to treat hangovers. Some of them ranging from hydration, take a lot of water after, even during the process of taking the alcohol. But usually we want to take a lot of water, you hydrate, you could take a lot of carbohydrates. And then there's also the use of vitamin B complex. To what extent it works, but most people have been using that.
Okay, thank you. Let us go to the conclusion of our event. What can we learn from what we have heard from our brilliant panelists? From Professor Peter Gottlieb, we learned that headache can be categorized according to where help is sought. There is an increase of global analgesic markets around the world. Migraine and headache can occur to at least 2 or 4 times in a month. The use of paracetamol has increased to fight headache. From Professor Takuya, medication use for headache in Japan's acetaminophen, ergotamine, etc. Combination product in Japan also, aspirin plus acetaminophen, combined with caffeine. Headaches are more common in humans because of their menstrual cycle. From Dr. Luita, we learned that 58% of people in Africa use self-treatment for headache. COVID-19 has usually disturbed the life of people, making people stay at home, working at home. This has increased also the headaches possibility. It is important for pharmacists to know all about headache, including medication that are more close to the patients. They have a big role, an important role to play as health professional, close to the patient, to ask questions, to obtain response, but to know the style of life of people also. This is very important. With Dr. Mashi, we went through the medical causes of headache, infection, stroke, tumor, disease, many diseases. Pharmacological causes also can be alcohol, caffeine, as we had now. Headache can be in general symptom of many diseases. Choice of analgesic generally consists of 3 main agents: paracetamol, ibuprofen, or aspirin. We would avoid medication overuse. Thank you very much for that. But I want to conclude by saying this. we have realized that headaches is a big issue for our continent. But if we play our role as pharmacists, as actor of primary health care, I think we can avoid the consequences of headache in the body, in the people, in the community. That is why we should be involved on all the projects for fighting against headache and bringing more good products, ameliorating the access of products, quality products to fight against headache. But we don't have enough neurologists in our countries. That is why the role of pharmacy will be very important to fight against headache. Thank you very much. But I see that there is another question. Do we have time? No. And do we have time for that last question?
No, but what can happen would be that the people that have asked us can send their emails, the question as an email to webinars@fip.org. They would respond to you personally in your email. If you can do that, webinars@fip.org, please.
All our webinar is recorded and you will see it on the website of FIP. Thank you to the speakers. Thank you, Minita. Thank you, Dr. Mashi. Thank you, Professor Yumamoto and Professor Gotsi. Thank you very much to all the participants. Thank you. Have a good time. Stay safe. Bye-bye.
Thank you. Stay safe. Bye.
Thank you.